So, thank you. How you doing? Good. Thanks for coming. All right. So now that we discussed why it's important, we're going to have a small discussion here with the panel. I'm joined with Dr. McLafferty and what's your last name? Dr. Maier. Dr. Maier, nice to see you guys again. So we just discussed actually some really interesting epidemiology. We talked about different kind of ulcers and the actually impact on the healthcare system in general. Any questions from the audience first? Okay. So one of the ulcers that was shown by you, it was a really aggressive ulcer with a black foot, almost basically combined blacks. Can you tell us more about that?
I don't even remember which one it was.
The really bad one where there's almost like rivers of redness in between the black on the outside, involving the majority of the calf.
Was that the one that you had pointed out or asked about? Yeah, that gentleman was, it was complicated too. He had had a burn. He actually rescued a child from a burning building. And so he had venous disease and this complication of the burn, and just obviously complicated. So it took a long time of working with him. He had some chronic osteomyelitis as well.
Wow. Dr. McLafferty, have you seen any combined both arterial and venous ulcers in your practice? How often do you see an ulcer that is actually caused by both?
Well, it's funny you just asked that. I just gave a talk at the CLI conference this morning on that. You see it, well, the question is, how often do we realize that it's occurring? And that's probably low. The data, albeit not very much out there, shows that probably about a third of patients, 25 to 30% of patients, have combined venous leg ulcers with moderate to severe PAD. And I think the real take-home message is all patients with any type of wound on the leg need arterial evaluation. And if there's risk factors for atherosclerosis, even if the ABI is normal, if you have a recurrent or ulcer or recalcitrant ulcer or a large ulcer, you probably should be doing some other type of non-invasive imaging as well, whether it be duplex or CAT scan. And I just want to touch on this whole wound care integration. I think that it's really nice to see that the veins has got wound care as part of their course.
Yeah.
I think it's nice to see that veins is part of VIVA. But I can tell you, almost every institution is struggling with this kind of patient integration of wound care and making it more central. We're doing this at OHSU, we're doing this at Salem Health, we're doing it at the VA, and it's a real challenge, but it does serve the patients in a better way.
So in your institution right now, it's a challenge to have a combined multidisciplinary working together as a single unit?
Absolutely. I can tell you that I've been at OHSU now for 3 years, and there really isn't any type of integration at all. In fact, when I arrived there, I made a pitch, no wound care center, no HBO. This is a large medical center. I made a pitch to the leadership that they needed to get busy with patient-centered care for patients with chronic wounds. And the only thing that got their attention was reducing inpatient stay for diabetic foot ulcers, because they have no beds available. And when you start translating this into the bottom line for the hospital in terms of dollars and freeing up beds to get more patients in, then they start listening. But that said, OHSU now is going to have their wound care center opening in November, and it's been a 3-year process, and we're partnering with Hillogix, which I think is a good thing.
I really commend you for actually forcing that issue and then making it happen, because it's been shown that the care for patients is much better if they have some form of revascularization or actually venous therapy and they receive wound care immediately after. Dr. Maier, are you having the same problem at your institution?
Yeah, I think it's common amongst a lot of large teaching institutions. At the Cleveland Clinic, We have wound centers within the system, but it's still a matter oftentimes of coordinating care, as you astutely point out. So I think there is benefit from some of the business models that exist in terms of more standardized approaches with documentation and billing, those types of things. But it's difficult in a large academic center to pool different disciplines under the same roof because everyone has different strategies, different biases in approaching those patients. And I think sometimes those biases are reflected in our clinical approach. So if I'm a surgeon, the patient needs surgery. If I'm a non-surgeon, they don't. So I think it's very healthy to have these conversations where you bring multiple disciplines to the table.
You know, you raised my curiosity right now. So you're at Cleveland Clinic, where when you hear the word Cleveland Clinic, you think organization, streamlining. That's the kind of things that go through my mind. So Cleveland Clinic right now does not have a sort of isolated ulcer team or something like to that sort today?
There are wound centers within the system. The Cleveland Clinic, as large as it is, the only place really that lacks is the main campus hospital because of the enormity of it. But within the system, there are wound centers, and we're working to choreograph efforts and mirror that on the main campus.
Wow.
I'm a big believer that, this may be heresy for the wound care doctors out there who do a good job, but I really think that the vascular specialists need to get more in touch with their wound care centers, and whether they're leading them, whether they're being part of the panel, I think it's really important. And the other thing I would add is, we've really got to get podiatry integrated into the limb salvage teams and into wound care in a much better way. This is something I am really pushing this hard at the VA and at the university. The university has one podiatrist in family practice, and yet we are completely inundated with diabetic foot problems that require really more than just a vascular surgeon doing minor amputations. It's a lot more complicated than that. And people don't understand that there's a wide breadth of types of podiatrists. There's operative podiatrists, there's wound podiatrists, there's outpatient-based podiatrists, and I think that it's just a very poorly understood specialty, but one that should be welcomed into the limb salvage team and the wound care team.
I couldn't agree with you more. That is so correct, actually. Do you have something to say?
Yeah, I'm glad to hear you say that. I am a podiatrist. So I'm glad to hear you say the integration. I think it's important. Our model has been very successful. I'm actually appointed in vascular medicine. So amongst my partners, we have thrombosis and hemostasis experts as well as an interventionalist. So within that group, we really do offer a multidisciplinary approach, and that seems to be very successful.
That's great. And actually, Desmond, you've had demonstrated the multidisciplinary approach years ago, and you're currently part of one, right? Can you elaborate on your program?
Yes. So for the past almost 3 years now, I've been part of a primarily cardiology group, but we've also expanded our services to include things like, we have primary care now. We have sleep medicine, pulmonology. So, all these things do relate. And I think this is the way we're going. This is the way we're going to have to go too. And the demands of what's going on with diabetes and aging of the population and how we're all going to be reimbursed for this is really, it's all coming to a head. And I'm going to expound on this in a little bit, but yeah, I've been fortunate. I had my own center for a long time, and it was kind of like parallel play with the interventionists and vascular surgeons in my community. But I found that coming under the same roof with the guys, we can really expedite care. Just having full vascular lab, if somebody has a suspected DVT, I just send them right across the hallway. Or if there's another concern that they've got a CLI issue going on, we can, really kind of move them to the head of the line. So it's invaluable.
I want to actually ask an uncomfortable question, because these questions is a reality, So this is in particular for interventionalists that do open an artery for an ulcer or close a vein for an ulcer, and that's it. So what do you have to say for the physicians that are doing that today, where they revascularize an artery in the vascular, or most vascular surgeons actually tend to care for the wound as well, but there are other specialties that don't. So what do you have to say to those guys that do open an artery or close a vein and no other plans for the ulcer?
I think our input, as we present to those guys, you know, the more information I give them, I think the better off. In terms of, you know, let's look at the you know, if we're trying to target the lesion, let's say, you know, tell them what artery we suspect may be blocked, or what issues going on venous-wise, and I think the more information they have available, just it helps them do their job better too. And I tell them all the things that we've done in treating them too.
So Robert, quickly for you, if I did a patient and I opened whatever vessels there were, and I played the game of let's wait and see what happens, which most of us do. You revascularize and tell the patient come back in 2 weeks, and we look at the wound and we have no clue in terms of what's happening. I'm a cardiologist in nature, so actually, let's say I'm speaking about myself. So how can we fix that?
I just think it really speaks to developing integrated teams. You know, I grew up in the 90s when everyone was playing in their own sandbox and fighting in the wars, and I just think that's I think it's much better now. But I think that the leadership needs to come together and realize that even if a specialty is doing one segment very well, it's okay if they're working with another specialty to kind of bridge the gaps in the needs for the patient. I can't say that enough. And I would say that, you know, you just kind of alluded that vascular surgeons take care of wounds too. I think we're better at it now, but as a specialty, overall, I don't think we're doing a great job in taking care of wounds as vascular surgeons. I mean, even on my own service, we make rounds, and it's like we revascularize the foot, but yet no one's paying attention to the foot. You know, can we wash the foot? Can we actually trim the nails on the foot? Can we actually take care of the foot? So my point is that once you start getting multiple specialties in the room, you start learning from each other, and then you can become more efficient, you know, and there's going to be disagreements that arise, but I think that overall the team approach is better.
It's positive disagreement. Dr. Maier, I'd like to end with you actually. Again, the same concept. Fixing an artery and then a patient does not heal, and now you're stuck with that patient. So although the artery is open, but the wound is not better. What kind of approach do you take to something like this?
Unfortunately, I think it's somewhat ironic. It boils down to communication amongst the different disciplines. So I have the benefit in our model of seeing patients with my interventional partner in the same room at the same time. So we look at it from a wound care perspective as well as an intervention perspective, but it literally boils down to oftentimes that communication piece. And I think regardless of whether or not you buy into the team approach or have that fully integrated approach within your institution, our hand will be forced in years to come as we look at different payment models and value-based care. The outcomes are going to dictate, you know, our revenue streams. So we're going to be forced to integrate those multidisciplinary approaches, whether or not you buy into it.
I think I don't mean to interrupt, Jay, but one of the things that, you know, we're constantly doing too is reassessing. So if the wound initially, let's say, starts to move and it's getting better, then it stalls. We're all over that and consult our interventionists too. And even when somebody does heal up, we also, especially if they've been a significant arterial condition or arterial issue going on, we will have them go back, you know, let's say every 3 to 4 months for just a reassessment, just to make sure that everything's still patent.
It's such a beautiful, actually, specialty, and there's a lot of growth to happen in it. So thank you so much for a great discussion.